Okay, so I want you to picture something.
Okay.
You're a doctor. You're about to look into a patient's ear.
Okay.
Usually, you expect the standard landscape.
Right, the familiar geography of the ear canal.
Exactly. Some pink skin, maybe a little yellow wax, and then, the pearl gray shimmer of the eardrum, standard stuff.
Yeah.
But this time, you look in, and you are greeted by something just distinctly wrong. There's a mass in there.
Mhm.
It's reddish. It's smooth, kind of lobulated, almost like a tiny cluster of grapes. It looks wet. It looks incredibly fragile. And you just know instinctively that if you were to touch this thing with a metal probe, even barely, it would immediately start to bleed.
It is a visceral image, isn't it? It just triggers that something is not right, alarm in the brain.
It really does.
What you're describing, it isn't a scene from a body horror movie. It is a very specific, very telling clinical sign.
It's called an oral polyp. And today we are doing a deep dive into a specific case study that centers around this angry little red mass. We have a young male patient. He walks into the clinic. He's sitting comfortably, chatting away. I mean, if you saw him at a coffee shop, you'd think he was the picture of health.
But inside his left ear, there is a ticking time bomb.
That is exactly the phrase that jumped out at me from the source material. A ticking time bomb.
Yeah.
So our mission today is to decode that signal. We're going to unpack the sources to understand what this polyp is actually telling us. Because as I learned reading this, a polyp is almost never just a polyp.
That is the crucial takeaway. I mean, today isn't really about a simple skin tag. It is about understanding a concept doctors call unsafe ear disease.
Unsafe ear disease.
We're going to trace the path from a simple physical exam all the way to a diagnosis of chronic suppurative otitis media, or CSOM.
And why the specific type of polyp is a massive red flag for something much more destructive hiding deeper in the skull.
Exactly. It's a detective story where the clues are microscopic, I mean literally millimeters in size, but the stakes are the patient's hearing, their facial movement, and potentially even their brain.
So let's start with the patient. As we said, young male. He's not clutching his head in agony. He's hemodynamically stable.
Right.
Which I assume just means his heart and blood pressure are fine.
Correct. He's not in shock, he's not running a fever, he's just a guy with an ear problem. And that's the trap.
How so?
In chronic ear disease, the patient often looks totally fine until they suddenly aren't.
Yeah.
It's a slow burn.
Okay, so the doctor starts with the local ear examination. First, they look at the outside, the pinna, the area behind the ear. And in this case, everything looks normal. No scars from previous surgeries, no weird holes or sinuses, no tenderness when you push on the mastoid bone behind the ear.
Right. The frame of the picture is normal, but then they grab the otoscope to look at the canvas, they look inside the left ear canal.
And that is where the scene changes drastically.
Right.
Drastically is the word. The source describes the canal skin as thickened and edematous.
Which is just medical speak for swollen and waterlogged. Think how your fingers look after being in the bath too long, but, inflamed.
And the opening is actually narrowed because of all this swelling. But the star of the show, or maybe the villain, is the discharge. The notes say it's profuse, thick, mucopurulent discharge.
Mucopurulent means a mix of mucus and pus. It's thick, it's sticky, and it's actively leaking.
But here is the detail that really made me gag a little. The notes specifically mention it is foul smelling. Now, is that just because it's an infection, or does that smell mean something specific?
I'm glad you caught that. In otology, the study of the ear smell is actually a diagnostic tool.
Really?
A foul, rotting odor is distinct. It's not just a dirty smell, it suggests anaerobic infection, but more importantly, it often suggests that bone is being destroyed.
Wow.
It's the smell of Astitis bone rot. It's a hallmark of unsafe disease.
Okay, so we have the smell of bone rot, and floating in this mess is the polyp we mentioned. It is obstructing the view of the eardrum completely. You literally cannot see the tympanic membrane.
It's like a curtain drawn across the room.
The notes describe the polyp as soft and mobile, and here is a paradox I found fascinating. It is insensitive to light touch.
That is a fascinating diagnostic clue, isn't it?
Yeah.
I mean, usually the ear canal is incredibly sensitive. If you've ever accidentally poked the wall of your ear with a Q-tip, you know it hurts like crazy.
Right, it makes your eyes water.
Exactly.
Yeah.
The skin there is very thin and packed with nerves. But this polyp, it has no nerve supply for pain. You can probe it, move it around, and the patient won't feel a thing. However, as you mentioned in the intro, it is incredibly fragile. It bleeds on touch.
So you have this numb, bleeding, blocking mass, and it seems to be coming through a perforation in the eardrum originating from the middle ear itself.
Which tells us the problem isn't in the canal skin. The problem is deep inside the middle ear space. The polyp is just the tip of the iceberg poking out through a hole in the drum.
Obviously, with the canal blocked by a grape-like mass and a bunch of pus, the hearing is affected. The notes say the patient can hear a conversational voice on that left side, but he cannot hear a whispered voice.
Which is a quick bedside way to screen for hearing loss. But to really understand what's happening physically, they did tuning fork tests, specifically using a 512 hertz fork.
I love the mechanics of this. It feels very old school medicine, like physics in action. Let's unpack the Rin test first. In this patient, the Rin test was negative on the left side.
Right, so normally if I hold a vibrating tuning fork in the air next to your ear, it should sound louder than if I press the base of the handle against your skull bone behind the ear.
Air conduction is better than bone conduction.
That's a positive Rin.
Yeah.
Exactly, it's a funnel. But in our patient, the result was reversed. Bone conduction was greater than air conduction.
Which makes sense, right? Because the ear canal is plugged up with the polyp and the pus. It's like trying to talk through a closed door.
Precisely. It confirms a conductive hearing loss. The inner ear, the nerve part, is working fine, but the delivery system is broken.
Then they did the Weber test. They put the vibrating fork right in the middle of his forehead, and the sound lateralized to the left ear, the bad ear.
This is one of those things that always confuses medical students, but it makes total sense if you think about it.
Is it like when you plug your ears with your fingers and hum?
That is the perfect analogy. Try it.
Yeah.
If you plug your ears and hum, the hum sounds incredibly loud inside your head, right?
Yeah, it booms.
That's the occlusion effect.
Ah.
By blocking the ear canal, you trap the bone vibrations inside. Our patient had a natural plug made of a polyp and infection.
So the sound gets trapped.
Exactly. The sound gets trapped in the bad ear and sounds louder there. It confirms the diagnosis, left-sided conductive hearing loss.
Okay, so we've established he can't hear well because of the blockage. But before we jump to what the blockage actually is, there was one more safety check the doctors did. And this one feels incredibly high stakes. They did a comprehensive neurological assessment, specifically checking the facial nerve.
This is non-negotiable. You have to remember the anatomy here. The facial nerve, the nerve that lets you smile, blink, raise your eyebrows, It runs through a tiny bony canal right next to the middle ear,
So it's millimeters away.
millimeters away from where this infection is festering. So if the disease eats through that thin bone,
You get facial paralysis.
you get facial paralysis. The patient's face would droop on one side. It's devastating.
Thankfully, our patient was pristine. He could wrinkle his forehead, close his eyes, smile symmetrically.
That is a huge relief. It tells the doctor, okay, the disease is aggressive, but it hasn't broken out of the ear yet.
They check for dizziness too.
Yeah. They also checked for dizziness, vestibulocerebellar assessment, and that was normal too. No nystagmus, no balance issues.
So let's recap. We have a young guy, leaky, smelly ear, a red polyp blocking the view, hearing loss because of the blockage. But his face works and his brain seems okay.
Right.
The expert in the source file puts this all together and gives a provisional diagnosis.
Oral polyp secondary to chronic suppurative otitis media, or CSM, but specifically the attic-control type.
And the source puts unsafe in parentheses next to that. Unsafe. That's a scary word to see on a medical chart. What specifically makes it unsafe?
The word unsafe in otology almost always implies the presence of a cholesteatoma.
Cholesteatoma. It sounds like cholesterol, but it's not, right?
No relation to cholesterol. It's actually a skin cyst
A skin cyst. That sounds, I don't know, kind of benign. Why is a skin cyst a ticking time bomb?
because of where it is. Think about your skin.
Yeah.
It sheds, right? Dead skin cells flake off constantly. On your arm, they just fall away. But imagine if you had a bag of skin growing inside a closed bony box like the middle ear. The skin sheds, but it has nowhere to go.
It just packs in tighter and tighter.
Exactly. It creates a ball of dead skin, keratin, and enzymes. And this ball, this cholesteatoma, starts to expand. It releases enzymes that dissolve bone.
Oh, wow.
It eats the little hearing bones. It erodes the bone, protecting the facial nerve. It can even eat through the roof of the ear and enter the brain cavity.
So it's not a cancer, but it acts like one. It invades.
That is the perfect way to describe it. It is locally destructive. And the polyp is just the body's reaction to this nasty, expanding cyst.
The body fighting back.
It's granulation tissue, the body trying to heal and fight the infection caused by the cholesteatoma.
So the polyp is the red flag waving from the canal saying, hey, there's something eating the bone back here.
Exactly.
Now, the doctors have to be thorough. The source lists a differential diagnosis. Basically, what else could this be? Because while this unsafe CS is the most likely, there are scarier things on the list.
You always have to rule out malignancies. Squamous cell carcinoma, skin cancer, or the ear canal can look exactly like a polyp.
The list also mentions glomus tumors and schwannomas.
Benign tumors, but they bleed heavily and occupy space. And then there are inflammatory conditions like Wegener's granulomatosis or even tuberculosis of the ear.
Wait, tuberculosis in the ear.
It's rare, but yes. We usually think of TB in the lungs, but it can infect the ear. Tuberculosis otitis media usually presents with pale granulations and painless discharge. It's on the list of things you don't want to miss.
The expert lists red flags for malignancy signs that would make the doctor start sweating.
Imagine looking at that polyp. If the surface was ulcerated looking raw and eaten away, if the patient said it had grown rapidly in the last few weeks,
Or if they had facial paralysis.
or if the patient had facial paralysis, or if the CT scan showed jagged, irregular bone destruction, those are the signs of cancer. Luckily, our patient doesn't have these blatant signs, but you can never be 100% sure without testing.
Which leads us to the detective work. We have a strong suspicion of cholesteatoma, but we need proof. The source says the essential investigation, capital E, is a high-resolution CT of the temporal bone.
You cannot operate blindly in this region. The anatomy is too complex. The CT scan is the roadmap.
What exactly are they looking for on the scan?
They're looking for the extent of the destruction. Is the ossicular chain, those 3 tiny hearing bones, intact, or has the cholesteatoma eaten them?
Okay.
Is the mastoid bone behind the ear full of air, or is it full of infection? And crucially, they look at the tegmen. That's the thin plate of bone, sometimes paper thin, that separates the ear from the brain.
And if that's eroded?
If that's eroded, the surgery becomes much more dangerous because the brain is exposed.
While waiting for the scan, there's an urgent need for an examination under a microscope, or EUM.
Right, and this isn't just looking, it's active. They use a powerful microscope and a tiny suction device to gently clean the discharge,
To see what's underneath?
to see what's underneath, and to see where the polyp is rooted. Is it coming from the attic, the posterior wall?
Yeah.
And they look for cholesteatoma flakes, bits of white keratin debris. If you see those white flakes, the diagnosis is basically confirmed.
Now here is a controversy the source brings up that I found really surprising. The biopsy. To snip or not to snip? My gut instinct says it's a mass biopsy to check for cancer, but the source says it's controversial but important.
It creates a real dilemma for the surgeon.
Why? What's the downside of checking?
2 big risks. First, bleeding. Remember, this polyp is vascular. If you snip it in the clinic chair, you might get profuse bleeding that is very hard to stop without surgical equipment.
Okay, messy, but not life-threatening usually.
But the second risk is darker. If it is a malignancy, there is a theoretical risk of seeding the tumor.
Oh no.
By cutting into it, you might release cancer cells into the bloodstream or surrounding tissue, effectively spreading the cancer you're trying to diagnose.
Yikes. So by trying to find the cancer, you might give it a highway to the rest of the body.
Exactly. So they don't just snip every polyp they see. They usually reserve biopsy for cases where the appearance is atypical, if it looks really nasty, ulcerated, or friable, or if the patient isn't responding to standard treatment. And often they'll wait to do it in the operating room.
Where they can control everything.
Right.
Okay, so we have the diagnosis unsafe CS with a cholesteatoma. We have the scan pending. Now we need a battle plan. The source breaks this down into phases. Phase 1 is acute management.
Or cooling it down. You rarely want to rush straight into major surgery on a hot, infected, pus-filled ear if you can avoid it.
Because the tissue is angry.
The tissue is angry, it bleeds easily, anesthesia is harder. You want to reduce the inflammation first.
The tools for this seem pretty standard but rigorous. Intensive oral toilet, which sounds awful.
It's a terrible name, isn't it?
Yeah.
It just means cleaning the ear out. Daily microsuction is key. You have to vacuum that pus out so the antibiotic drops can actually reach the tissue.
Right.
If you just put drops on top of a pool of pus, they do nothing.
And the drops. The source specifies ciprofloxacin 0.3% with dexamethasone.
Antibiotic plus steroid. Kill the bacteria, calm the swelling.
There is one rule in phase 1 that is bolded in the text. Strict water precautions.
Vital. If you have a hole in your eardrum, water from the shower or a swimming pool acts like a delivery system for new bacteria. The patient absolutely cannot get that ear wet.
No swimming.
No swimming, and use a silicone plug when showering.
Phase 2 is the decision point.
Right. After, say, 2 to 4 weeks of this intensive cleaning, vacuuming, and drops, you reassess. Is the ear dry? Did the polyp shrink?
If it resolves, great. But in our case, with an underlying cholesteatoma suspected, the polyp is likely to persist because the root cause, the cyst, is still there.
Which leads us to phase 3, surgical intervention. And here, the expert in the text delivers a core maxim that defines this whole condition.
What's that?
Oral polyp is a sign, not a disease.
Oral polyp is a sign, not a disease.
So if a surgeon just went in and snipped off the polyp and sent the guy home, that would be what?
It would be negligent. It would be like painting over a water stain on your ceiling without fixing the leaking pipe upstairs.
The problem comes right back.
The polyp will grow back, but worse, the cholesteatoma will keep silently eating the bone. You have to treat the underlying cause.
The procedure listed to fix this is a modified radical mastoidectomy, which sounds intense.
It is major surgery. Think of it like a renovation where you aren't just repainting, you are knocking down walls.
Knocking down walls.
Literally. The surgeon drills out the mastoid bone behind the ear. They remove all the honeycomb air cells that are harboring infection. They lower the bridge of bone to open up the attic of the ear. They create one large, smooth cavity that connects the mastoid and the ear canal. And the goal is to get every microscopic bit of that skin cyst out.
Every bit. If you leave even a few cells of the cholesteatoma, it will grow back. The goal listed in the source is creating a safe, dry ear.
And notice what isn't the primary goal: hearing improvement.
Yeah. That's a hard conversation to have with patients. They want their hearing back. But the surgeon's priority is safety.
Right.
We're trying to prevent meningitis, brain abscesses, or facial paralysis. If we can reconstruct the hearing mechanism, maybe put in a titanium prosthesis for the hearing bones, that's fantastic. But it's a bonus. The priority is to get the disease out.
Let's talk about the future for this patient. The surgery is successful. The polyp is gone. Is he cured?
Ideally, yes. The success rates for polyp removal are high 90-95%, but there's a recurrence rate of about 10 to 20%.
Because of that leftover cell problem you mentioned?
Exactly. This is why follow-up is for life. These patients need their ears cleaned annually, indefinitely.
Now, the source mentions some recent advances that are changing how this battle is fought, and this is where technology really steps in.
It's exciting stuff. For a long time, surgery was purely with a microscope. But now we're seeing endoscopic ear surgery.
Like the cameras they use for knee surgery.
Exactly. Instead of looking through a microscope from the outside, you put a tiny high-def camera right inside the ear. It lets you see around corners.
Oh, wow.
You can look into the hidden recesses of the middle ear to find those last sneaky bits of cholesteatoma that a microscope might miss.
That seems like it would lower the recurrence rate significantly.
It does. And they're also using lasers now, specifically for the polyp. You can use a laser to vaporize the base of the polyp.
And that avoids the bleeding problem.
It seals the blood vessels as it cuts, so you don't get that bleeding we were worried about. It makes the surgery much cleaner and more precise.
It's amazing how we've gone from smelling bone rot to vaporizing tissue with lasers. So, to summarize this journey, we started with a young man who just had a leaky ear.
A leaky ear that turned out to be a complex case of anatomical detective work.
We went from a visual inspection of a bleeding red mass to tuning forks confirming the sound was trapped.
To a CT scan, revealing the potential bone destruction.
And finally to a surgical plan that involves drilling into the skull to make the ear safe again.
It really highlights that in medicine, the surface problem is rarely the whole story.
It's humbling. You think, it's just an ear? But the complexity packed into that tiny space, the physics of sound, the chemistry of infection, the proximity to the brain is mind-blowing.
And that leads me to my final thought on this deep dive. When you think about the human body, we often ignore things that don't hurt. This polyp didn't hurt. It was insensitive to touch. But it was bleeding. It was foul smelling.
It was shouting in its own way.
Exactly. A simple polyp is rarely just a polyp. It is the body waving a frantic red flag saying, look deeper. There is a problem at the root. It reminds us that our bodies have these built-in alarm systems, and our job, whether as patients or clinicians, is to listen to them before the damage becomes irreversible.
Look deeper. I like that. Well, next time you feel your ear pop or hear ringing, maybe take a second to appreciate the incredible, fragile machinery working away inside your head. And if something doesn't feel right, get it checked out. Thanks for listening to this deep dive. Stay curious.